But tell me what you do as Chief Medical Officer of Philips. What does that entail?
That's a great question, Dave. I think what I was hired to do and what I am doing every day is bringing the clinical insights in the hospital and try to make the connection between what is happening in the outside world, how doctors feel, how C-suite make decisions, into the decision-making, the strategy, the roadmaps of Philips. And at the same time, I try to make the bridge the other way, adding credibility to Philips as a health technology company, translating the Philips strategy and the Philips vision to the customers I am visiting on almost a daily basis.
So, okay, you spend a lot of time talking to customers. And what do you think is the main message that they're giving you that I presume then you're bringing back into Philips? You know, what's the significant biggest issue for the people you talk to in healthcare across the board?
It's not easy to say there is only one, because what doctors, but especially C-suite, has to do now, they have to juggle different balls at the same time. They have to fill goals or to meet goals that are to be met all at the same time. First of all, they need to deliver better patient care, which is outcome-based, a better outcome for patients they are treating. Second, they have to do that at lower cost. There is a huge pressure on costs in healthcare because as it is going now, it is unsustainable. These two things together are already quite difficult. And then at the same time, patients are more taking their health and their wellness in their own hand. They want to be in the driver's seat, so they want to get a better patient experience. And last of not all, the fourth is that they have to deal with the increased burnout rates in doctors.
Yeah.
So healthcare, professional satisfaction, patient experience, outcome-based care, as well as lower costs. All these four goals are on the minds of these people all the day.
That's a lot to have on your mind to try to solve all at once.
Yeah.
Although, obviously, as a technology journalist, my own belief is that leveraging, and this is the belief Techonomy has, that's why we have tech in our name, that technology is a tool for progress of the highest order, and if you really embrace it, which most businesses don't do sufficiently, you can really make a lot of radical positive change. And then Eric Schmidt last night in the keynote here basically chastised the healthcare industry for not embracing tech enough, not using cloud-based systems and other modern tools enough. Do you agree that healthcare is generally behind in that?
Yeah, I agree with him that healthcare is lagging behind what is happening in the banking industry, in the retail and in the travel industry. And there has been publications and opinions on that, why they are lagging. There is not one reason, but there is a sort of compilation of different reasons that are specific for healthcare. First of all, there is a big legacy of a workforce that is working in an autonomic way and that is averse of change.
Yeah.
Second,
is that doctors mainly or everybody?
That is mainly doctors.
Mainly the doctors.
That's mainly doctors. Second is there is no financial incentive.
Right.
I believe that in these other industries that we mentioned, there was a financial incentive to change.
That's especially true in the United States, I assume.
Yeah, and there is not a very huge incentive yet. It will come to change, to change that system. And third of all, most important of all, the third one is that the digital solutions that are now there for doctors to use are not yet living up to their expectations. So when you have these three, there is enough reason for doctors to hold back and say, listen, let's wait till it is really necessary. Maybe my successor can do it. I have always done it like that, so I will continue doing it. And let's wait till the services that are brought to me, the solutions that are brought to me are better equipped to fill my unmet needs.
Are we on the way to better digital solutions? I mean, this is a huge commitment of Philips, I know.
Yeah.
So how much better are they getting? How fast?
I think they are getting better. And the reason why I think they're getting better is that we are listening more to customers. We are really trying to understand their unmet needs, and we try to cater for these unmet needs with crafting solutions that fit to their particular problems. So by doing that, not by just having a sort of software and throwing it at them and start using it, we try to co-create together with them. And I have a very good example on that, and that is our Azurion product, which is a cat lab service. Now, if you have been in cat labs before, you know that it's a frightening environment with a lot of machines, a lot of people running around. What we did together with doctors is bring all the information they need to do a procedure on a cardiac patient, first time right, and as fast as possible and as effective as possible. All the information they need we have at their fingertips, literally. So by designing these software tools, these digital solutions, together with the doctors, we can probably bring healthcare informatics to the market that is resonating with them better and makes it easier for them to adopt them.
Well, one of the themes, the main themes of this session is the global impact of technology to improve health, and even, reaching out to some very aggressive goals to bring the whole world into the kind of lifestyle that we enjoy, considering how deprived, especially in terms of healthcare, so many billions of people in the world are. I'm curious if you think that because I know you travel all over the world all the time in your job, do you think that in the course of trying to address the problems of the whole world, even the neediest, the least affluent, that we may develop systems that then really end up improving health for everybody?
I really believe that, and not only because I believe it, but because we have to. If you look at one of the biggest challenges now is chronic diseases, non-communicable chronic diseases. They are taking up more than 80% of the healthcare spend now in the world.
Everywhere, yeah.
80%, 70 to 80%.
It's obesity, patients, things like that.
Obesity, diabetes, hypertension, respiratory problems, and often in a mix of multiple of these diseases together in a certain patient.
Right.
If you realize that almost 4/5, 80% of these patients with chronic diseases live in low and middle income countries, there is no choice of trying to address this with the new tools and the new informatics that we have to. We have to.
Yeah.
We have to believe it. There is no other choice.
Well, what are some ways that that's being done? What are some early ideas that you guys have about how to, whether it's for those chronic diseases or just in general, getting to those most needy people? What are some tools we have now?
There are now tools that we have already, and one of the examples we can talk about is our Lumify. Lumify is a portable ultrasound probe that can be connected to an iPad or an iPhone.
Really?
And that can be used in anywhere in the world. That's one example. Another example is a sort of combination of two apps that we tested in Indonesia for pregnant women. We know that the mortality of both the mother and child mortality in pregnancy is highest in the backwaters of Indonesia. So we developed an app that can be used by a more or less untrained healthcare worker going to the pregnant mom in these remote areas. And we developed an app that can be used by an expert in a center far away.
Right.
So the healthcare worker inputs data of this pregnant mom somewhere far out, streams these data to the central station where an expert looks at them with his own tooling and sends back the good advice. We did a study in Indonesia and we could reduce the child mortality and mother mortality to almost zero in 500 pregnancies.
Yeah, and I know the numbers for Indonesia in terms of obstetricians, it's like ridiculously low. Like, I think there's maybe less than 1,000 in the country, and they have 400 million people or something like that?
Yeah.
I mean, so if we don't have those solutions, a lot of people are going to die.
Yeah, yeah. But still, we have to, the way to address it is also to work with organizations that have the goal of improving that. I was at, yesterday morning, I was at the American Cancer Society in Washington.
Yesterday?
And I talked with the responsible person there for bringing oncology care to remote areas, to underserved areas. So that has different aspects. She told me that there were only 2 oncologists in Ethiopia a few years ago, 2.
Wow.
Now there are 9.
Wow.
9 is still far too less to cater for all the patients, the increasing cases of cancer in Ethiopia. But if you could give these 9 or maybe 10 or 15 people extra tools to do diagnosis, for example, digital pathology.
Right.
If you could put a simple digital pathology scanner somewhere in Ethiopia, doing the surgery is not the most difficult part. You can scan the biopsy and you can have the biopsy read anywhere else in the world and come back to that remote area with a suggestion for a therapy.
In your travels, do you find that the governments of these less developed countries recognize this opportunity of telehealth and remote digital tools and that they're willing to pay for it? Or who is going to pay for that if we're going to solve that problem?
If we want to solve that problem in a sustainable way, we will have to look for sustainable financing. So it depends, it really depends on the country that you're working with. Some of the countries are really passionate about doing this and putting money there for the long run. In some of these countries, we work with the government, for example, to put community life centers, which deliver the basic care for people in a remote area, so that they don't have to travel long distances to go to the first hospital. And in other countries, we still have to work with NGOs, and that is good as a starting point. But in the end, we have to come up with business models that are sustainable also on the long run.
Well, I want to come back to the United States, but before we get off the global thing, we should talk about Philip's commitment to the Sustainable Development Goals and your goals to really be involved with a significant leap forward for global health. Talk a little bit about the company's goals and how you think about that.
The company is the company, the people in the company, and our CEO is very passionate about the Sustainable Development Goals of the UN, especially the number 3, which is on health and wellness. And we have put it in our mission. Our mission is to improve the life of 3 billion people in 2025. 2025. 300 million of those are lives in low and middle income countries and underserved areas. And we really track that. So we are working on solutions that are also addressing the needs of these people in these areas.
Okay, coming back to the States, and this issue of remote combined with local services. I know you've done some very interesting stuff in South Dakota, which is a remote, very dispersed part of the United States. Talk about what's happened there.
Yeah, that's about increasing access to great care, to optimal care, also in rural areas. The Dakota system that we have worked with is the Avera system, and they have a number of hospitals that are far out,
small and many different places.
And they have an e-care model there. Yeah. They put on top of that our eICU solution.
An eICU
solution is where you can monitor patients continuously and remotely. So just for the visualization, you have a team of people that is working what we call on the hot floor. Nurses and doctors treating for patients at the bedside. At the same time, there is another team sitting in a console getting all the data from all these patients from these remote areas together on different screens, on different dashboards. And they can monitor these patients continuously, not fragmented, not discontinuously, but continuously. And they can feed back to the hot floor, to the patients, to the people working with the patients directly, when a patient is slowly deteriorating. So the action that can be taken is early, is preemptive, and it's usually cheaper.
Yeah.
And we could demonstrate together with that IDN in South Dakota that they could save more than $60 million in 1 year.
Wow.
Because they didn't have to go in a patient room when everything has already gone out of bounds, and they had to bring in everything that is necessary to recover the patient. They could do it preemptively and cheaper before that. And what is more important, they feel that they saved more than 250 lives doing that.
Wow, just in South Dakota?
Yeah,
wow.
Just in that area,
I want
just in 1 year.
Invite anybody who has questions or comments to feel free to get your hand up. But I'm going to keep going, but if you have ways you want to jump in, please do. You know, you talked before about this challenge of not feeling the financial pressure, right? But so many in the healthcare system don't even feel they have to use tech to save money because, I mean, especially if you're a provider, you're in the business of charging for procedures, the payers are the ones who will pay for pretty much anything, more or less. You know, how does one break through that cycle? Because I know you have some ideas about that.
Yeah.
You've tried some interesting things.
Yeah, it's not so much my ideas. You just have to look at the reimbursement and the payment system in different countries. For example, if you would use Sweden as an example, Sweden has a sort of social health care. So everything is paid by the government out of taxes. So they can deploy modules of care that are much less expensive, that push patients out of the hospital, that can monitor patients at home, because they will decrease the cost.
They do have financial incentives.
And they do it. They have the financial incentive.
Right.
When the system is not incentivizing that, for example, if your revenue, your cash flow, inbound cash flow decreases when you're going into a system of home monitoring instead of having the patients in the hospital,
right.
Hospitals are not going to do it.
Right.
So it's completely dependent on the government and the governing system of the different healthcares.
So I know if you have national health care, obviously the incentives are aligned like they would be at, say, Kaiser Permanente, where the insurer and the caregiver is the same organization. But when that's not the case, are there ways to sort of bring the parties together and make more financial incentives to bring in some of these innovative ideas?
Now, our deep conviction in Philips is that nobody can do it alone. Nobody. And we echo what big leaders in healthcare are saying, like Bernard Tyson of Kaiser Permanente. Nobody can do it alone. So if we can get at the table with an insurance company and a provider and Philips and try to understand the system and then do a sort of proof of concept, it works. And we have done that, or it is happening. We were not involved in that, but it is happening in the Netherlands with one of the insurance companies at one hospital, and we are doing it together with a hospital in Germany.
But the way that would work is people, you know, even if normally the incentives might not be there for seeking the cost savings, when you do that, all the parties can share in the savings. Yeah. It spreads the incentive out. Do you think that's even possible in the United States?
I think it's possible.
We really have a problem with the incentives here.
No, I think you have a possibility. You can, if you are going into this co-creation session, and that is something different from selling a box with a CT scan and a service contract and come back in 7 years. Here you have to take the time to understand the unmet needs and say, okay, we make together, we co-create a solution for your unmet need. And we are going to do this in a risk-sharing fashion.
Right.
We can share financial risks. We can even share patient outcome risks. And we agreed together on KPIs underpinning that. And you can do that with IDNs here in the United States and everywhere in the world.
So this is something Philips is increasingly seeking to do with your customers in as many situations as possible.
Absolutely.
Yeah, that's great. That's really attractive.
Yeah. That's the new business model.
Yeah.
And we want to increase it over time.
Okay, I know you yourself interviewed somebody for an hour earlier today, who's the CIO of Phoenix Children's Hospital.
Yeah.
So talk about what that was like. I know you had some serious takeaways from that. It was apparently an excellent session, but what was your biggest takeaway from that?
Now, my single biggest takeaway was on safety and security. And I never realized that. And what David Higginson told me is, listen, we have always the intention to connect everything to the internet, to the Wi-Fi of the hospital for...
We call it Wi-Fi, but okay.
Whatever. No, I'm a Belgian. We say Wi-Fi.
Belgians can say Wi-Fi, but I got to translate here. So.
Okay, it's Wi-Fi. Okay. In any case, to the intranet of the hospital, you have to think twice if you want to do it with all your products you have there. For example, an infusion pump. And he told me the example. They have the infusion pump to give drugs to a patient. And they are programmed for the right dose and the right speed.
And it's digital.
And it's a digital pump. It is not connected to the Wi-Fi.
Right.
But there is an ISB port there. So he gave that pump to a software engineer who didn't know anything about healthcare.
Yeah.
And he said, fool around with it and see what you can come up with. In 1 hour, the pump was completely reformatted, so to speak, internally. The speed of all the protocols that were inside were different. The speed of the drug.
So he hacked it completely.
But that was only one pump. Just imagine that you do that by connecting all your 5,000 pumps. In my hospital where I was working before, we had 5,000 of these pumps are connected to the Wi-Fi, and somebody in the lobby says...
You can say Wi-Fi, I was just giving you a hard time.
Somebody in the lobby says, I'm going to hack it unless you give me so much. So you have to do... Another example that he talked about was a defibrillator.
Right.
Now defibrillators in hospitals are still logged when they are used by hand in a logbook.
They're logged by hand, yeah.
And he said, let's keep it like that, because connecting them to the Wi-Fi is not going to help much, and it will create problems. This is a completely I can understand that, but it's a completely different situation when you are putting these defibrillators in the community, like in healthy heart cities.
They have to be connected.
There's nobody that's going to log them.
They got to be connected.
They got to be connected. So his message was, think twice if connecting them to the internet is wise and is necessary. If it's necessary and wise, do it. If it is not necessary and not wise, don't do it, because of security issues.
But that
was his message.
That doesn't disturb you as a healthcare informatics company? I mean, is the security issue, I mean, do you think the cybersecurity challenge is so great that it could slow down some of the progress we want to see in digital health?
I think it's already doing that.
It's already doing it. Wow.
I think that the security and safety is an issue, and we can never be 100% secure and safe. The proof you see every day in the newspapers that hospital systems are hacked. So, and that is already keeping hospitals back of, for example, allowing other partners to put their data in the cloud. And we will have to deal with that going forward. We take the maximum precautions to be as secure, as safe as possible in current day standards, but we understand that it will never be 100%.
Wow.
And for a hospital administrator, it is even more important to keep the data of his patients safe and secure.
Wow. So, you know, when you think about at the macro level, going back to our big global topic, you know, if we want to take away from this conversation a fundamental insight about how technology is going to change the landscape for digital health and bring much more inclusion, what would you say the central message that we need to be thinking about is?
The central message that we think about is talk with us about your unmet needs. And that's an internal and an external challenge. An internal challenge, we have to convince our people to really go into engaging conversations with our customer, to understand what they want, and to try to reach a long-term strategic partnership with them in order to solve their unmet needs. And at the side of the provider, it's the same thing. They have to be prepared to talk with us, to put their problems on the table, and we should be trustworthy to talk with them about their products and not being in the sales mode the first time we meet them. And that is the new, the ambition we have and the new attitude we have to learn externally and internally.
Do you think, Philips used to be in the business of light bulbs and all kinds of other things. Now that you've gotten rid of all those unrelated businesses, do you think the company has a capacity for listening like that they really had to cultivate and have now developed? I mean, that was part of the whole purpose, right? Focus in, make healthcare the whole thing with Philips, right?
We are a learning organization, but we are learning fast.
Yeah.
So we want to transform medicine. We want to not only to serve the wave of transformation in healthcare, but to break the wave, to shape healthcare as it is going forward. And the proof is that we are really incentivized to make this solution partnerships a bigger proportion of our revenue. It's now close to 30%, and we have the ambition to increase that to 35%. So it's really something strong in the company.
The kind of thing give an example of the kind of solutions you're talking about when you say that.
The most simple solution is it's a managed equipment service. It's already there, it's building blocks we have. And instead of selling CT scans, MR, software stacks one by one, we do a long-term partnership with a customer, for example, with Karolinska Hospital in Stockholm, where we have a 14-year contract and we manage their image department, hardware, software, solutions, services. We even integrate devices and software of other vendors in that. That's a simple one.
Are there sometimes outcome-based measurements included in those arrangements?
That is not yet included there.
But sometimes
if you go to the more difficult one, the ones that you're really focusing on particular needs of a certain customer, we are prepared to go into these negotiations with them in a risk-sharing mode. Wow. and a shared KPI mode.
Wow, that's great. Do we have time to keep going? I wanted to ask you some things about data, if I could. Can we do that?
Oh yeah.
We didn't work on this before, but there's so much talk about data here at HIMSS, right? There's all these people that are selling devices to gather data. There's a lot of systems integrators. You've got Google and Amazon saying we're going to pull it together in the cloud and make it all easy for you. What's the reality from your standpoint of where we stand in terms of how well we're using data in healthcare at the macro level?
I feel we are not using it enough yet. If you only look at the data that Philips is collecting and cannot use because we have all this consent issues on that, on our monitors or our scanners.
And incompatible standards,
whatever.
Too, probably. Not,
yes. So
not of your fault.
It is not yet used to its full extent, but it's gonna be the future.
It has to be.
Because it has to be the future. Yeah. Data is the new oil, as was in The Economist last year.
They say that.
So, but just putting the data in front of the doctors is not gonna help. We have to help them, and our Health Suite Enterprise Edition is our big step going forward there. We have to help healthcare providers manage their data, analyze their data, annotate their data, and then translate these data in something that they can use in decision making to come to a better and first-time right diagnosis, to add stacks to that are specific for cardiology or oncology, for example, to use artificial intelligence and our insight to work these data, to do better treatment, to segment patients. There are so many use cases, but we have to help them translate data into actionable decision-making tools.
So we
can do that on-premise as well as in the cloud.
So that's a pretty high priority, not just for Philips, but for the whole healthcare industry. But you guys are really thinking hard about new ways of doing that across the board.
Yeah. We are doing that, and we have also I think we have a right to play because we have been in the healthcare business for a long time. We know healthcare in and out. And at the other side, we have a deep understanding and a deep customer intimacy out of our personal health solutions. So we can combine these two capabilities to understand much better the needs of customers and how they want to address their data and make their data to use for their needs.
Yeah, there's so many big issues. The way we think, the way money flows. I mean, going back to your things, you know, the way the doctors think, you know, all these things have to change for health.
Yeah.
And as an American, we look with envy on the systems in countries like your home country, Belgium or Netherlands or the UK with national health care. You know, we really don't have the incentives to make a lot of the changes we need, but we desperately have to start improving it. I mean, we spend all this money. We spend more money in the United States and we get less for it. It's just unacceptable.
Yeah, it is. But you know, there will be a barrier somewhere. You cannot go much farther in spending even more money and a bigger proportion of your national product every year on healthcare. So there will be systems designed to tackle that.
Yeah.
And the new paradigm, the value-based healthcare paradigm, is slowly getting traction. It goes slowly, it goes too slowly, as far as we are concerned. But there is no choice. There is no option of just increasing the healthcare spend for. No. So we will have to tackle that, and you see movements there, and irrespective of new governments and new administrations, the biggest assets in reimbursement of value will remain there and will be expanded going forward because there is no other choice. And I also believe that it will happen in the States. If you look at these wonderful examples, at these wonderful examples at Geisinger or Kaiser Permanente we talked about, or the Phoenix Children's Hospital that we already talked about in this conversation. These are so nice examples, and they will be showcases, and many people will follow.
Well, I just heard a presentation the other day about universal coverage, which is something obviously we don't have in the United States, but there is an increasing view that that's going to be a competitive advantage for the countries that have it, and the countries that don't have it are going to really be hurt over time. And by that logic, the US is going to be forced to address some of these structural impediments that cause us to be wasting so much money. But I just hope it happens. Agree. But thank you for all the good work you're doing.
Thank you.
Been talking to Jan Kimpen, the Chief Medical Officer of Philips. Thank you all for being here, and thank you, Jan, for a great conversation.
Thank you. Thanks, David.
Really good.